Welcome, esteemed guests and distinguished panelists. Thank you for joining us today. I am Shagun from ET Health World, and we are honored to have Dr. Prateek Sharma, a renowned gastroenterologist from the University of Kansas Cancer Center and a pioneer in groundbreaking research, leading our webinar titled Technological Disruption in Gastroenterology. As a distinguished figure in this field, Dr. Sharma brings his wealth of expertise as he navigates us through the transformative impact of cutting edge technologies reshaping the landscape of gastrointestinal care. Please note that you can send in questions on the chat box throughout the webinar, and Dr. Sharma will address those at the end of the session. Without further ado, let's delve into the future of this field with Dr. Prateek Sharma.
Okay, thank you, Shagun, very much for that introduction, and good morning to everyone who's joined. My thanks to ET Health World for setting this up, and to all of you for being able to join us this morning. So, what I will be talking about in the next several minutes or half an hour would be on what's new in the field of gastroenterology. And I'll start off by just telling you what these pivotal themes are, because I think that is what defines us today and what we'll be talking about. Is number one is the changing landscape, which several of you on the call are well aware of, that GI and gastro diseases are on the rise, not just in the Western world, but also in India. And a lot of things related to unhealthy lifestyle and environmental factors, which are playing a common theme and a role in not just gastrointestinal diseases, but overall healthcare as well. There's also been a development of specialty even within gastroenterology, which is a threat of care fragmentation, but also may lead to better specialized care. And so this leads to the theme of disruptive technologies, which I'll be touching upon today, including big data and artificial intelligence, therapeutic endoscopy, which is minimally invasive, and what other technological and targeted treatment interventions are now available in the field of gastroenterology. So that's going to be my theme for the rest of the session today before we get into the question and answer. So artificial intelligence is everywhere, including our smartphones, including online shopping, everything. And this is a field of computer science where intelligent machines and programs are deemed possible. Now, you will also hear about machine learning as well as deep learning, and both machine learning and deep learning are subsets of the field of artificial intelligence. Now, artificial intelligence is not new. This is a term which was coined back in the 1950s and 60s, but only recently, about 2017 in medicine, it started becoming extremely useful and popular because the computing power increased substantially, and the ability of the computers to distinguish even what the naked eye could see became so impressive that that's when it started being used in the field of medicine. So AI in medicine, let's just step back and see, why is it important? I mean, this is just from the US perspective, where we spend about $4 trillion every year just related to healthcare. And this expenditure happens on both the clinical side as well as on the administrative side, and these are listed for you here. And AI can help impact both on the clinical side as well as on the administrative side. And we'll talk about this a little bit, but it's important to recognize that. These are some more recent statistics about where the global AI healthcare market size lies. So you can see that this is in US dollars and billions. So it's about 20 billions today. But what is projected is that by the year 2030, close to $200 billion will be the global AI healthcare market size. So that's as far as the global market size is compared. And now, if you look at the Indian AI market size, and this is not broken down by healthcare sector or the industrial sector, but all of it, you can see that again, right now it's close to about $7 billion, but by 2030, it's projected to be close to $40 billion. So it is a very important issue, both in terms of what it can do, but also from a financial perspective as to what the wave of the future looks like. So I think it's very important and timely for us to talk about that. And if you look at it from the Indian perspective, one of the things which always is a stark contrast given the population of the country is that as compared to a global average of 150 doctors per 100,000 population, we just have 64. And of course, a large proportion of our patients live in the rural area where, again, AI could have a major impact. And so AI expenditure is expected to reach $12 billion and is expected to add $1 trillion to India's economy. Again, these are projections by 2035, and this is based on the Davos Forum in 2022 as to what the healthcare market and the AI perspective looks like in India when it comes to artificial intelligence and healthcare. So now let's look at the role of AI in the field of gastroenterology, and I'll start off by computer vision, which is the basic tenet of being able to recognize images and recognize subtle changes which may happen in that. So the first and foremost is looking at why do we need AI in gastroenterology and specifically in endoscopy. And this is just to tell you what the data look like for missing lesions during procedures. This is a study from 1997 in which it showed that an average of 20% of lesions were missed during endoscopy. This is a study done in 1997. And I just pulled this study from last month, similar type of a study, and it shows again that about 20% of lesions are missed during endoscopy. So have we really made any progress over this time period? Because we are still missing subtle areas of abnormalities when we do these procedures. And that's where this concept of computer vision comes into play. And this is how it works, is you look at areas. This is showing an intestine or a colon. At the top, a thumbs up means that it's clean. There are no lesions in it. At the bottom is a thumbs down, which is an angry looking intestine or colon, which means there are lesions in there. And you just feed all these images and videos into the computer and you train it by telling it what's abnormal, what's normal. And then through deep learning, the machine is able to learn and is able to differentiate and separate between what's good and what's bad, meaning what's normal and what is abnormal. And here it is. We're doing a procedure, a colonoscopy. This is a polyp that we find, and the machine is highlighting it for you. This is through CNN networks or deep learning. Also, on the left side of the screen, with the help of the speedometer, it's telling you what type of lesion is it. Is it non-neoplastic, which is green? What is the size of the lesion? So it can help grade and stage lesions during endoscopy for you. And so this is one aspect of artificial intelligence in endoscopy. How good is this? And so this is a very recent systematic review published in our journal a couple of months ago. 21 randomized controlled trials. So patients are compared with AI and without AI colonoscopy, more than 18,000 patients. And we looked at ADR, which is the number of adenomas detected during the procedure. And you can see that with AI, that number is 44%. Without AI, it is 36%. So shows that with the help of these boxes, you're able to detect more lesions with that. Now, you can argue is that because AI is working, will it make the procedure longer? And on average, AI added about 30 seconds additional time to every procedure as compared to a procedure which was done without AI during colonoscopy. So just remember that, yeah, perhaps it can add about half a minute to your procedure time, but it does help you recognize more lesions. Now, that was in colonoscopy. How about in upper endoscopy, in which you're looking at the esophagus and you're looking at the stomach? Similarly, you can see that this is a heat map which is generated by the AI machine, and it starts telling you and recognizing these abnormal areas here in the lower part of the esophagus. At the bottom, you see that blue bar, which is going from the left to the right. That is the probability of this saying that there is no cancer in this part of the esophagus, specifically in a patient with Barrett's esophagus. Now, here, the machine is detecting that there looks something which is abnormal. You inspect it carefully. It's starting to look at it. It's starting to recognize the pattern. And now it's telling you that the cancer, that this is probability that that was cancer, was close to 99%. So it can alert you to abnormal areas and lesions once you start looking at that in the esophagus. Same concept in the stomach. Here's something which looks abnormal. And so the machine alerts you to it, and it's telling you, okay, stop, look at this area. And it's telling you that it is a depressed type of a cancer occurring in the stomach. So initially, what I started off by telling you is that we tend to miss lesions. Perhaps this may be the answer, is that this can help reduce our miss rate of lesions. You can also identify the spread of the lesion with the help of artificial intelligence. Here it's showing you a cancer, but the AI is also marking you in blue color here what that extent is. I'll be talking about how some of these lesions can be removed endoscopically, minimally invasive without the need for surgery, and AI can help us in this area as well. Now, does AI help everyone? Now, what does that mean? Does it help everyone or not? And here's the concept. This is a study that we looked at in which it shows that those people who have a low rate of detecting lesions have a 10% improvement as compared to those who already have a high rate of detecting lesions, in which there is a 6% improvement. So perhaps those people may help that better. Next is the administrative side that I talked about. So that's on the clinical side as physicians when we are doing the procedures. But how about during looking at the landmarks during the procedure and recording of a number of things? So, for example, during colonoscopy, we try to reach the last part of the colon. We look at the appendiceal orifice, and then we start the withdrawal time, what we call. And the withdrawal time is a marker of quality, meaning, are you withdrawing too fast or are you withdrawing slowly? Because if you withdraw too fast, you could miss seeing lesions. So AI can help you there as well, in which it's guiding you here. If you start withdrawing too fast, that needle on the left will start going towards the red, warning you that, hey, please slow down. Maybe you're coming back too fast, and maybe you need to start slowing down to get a better look at the mucosa. It's also marking this landmark, ileocecal valve. So this is an area that we try to record in our procedure reports. Did we reach the ileocecal valve or not? And here you want to remain in the blue, which is an adequate withdrawal time during the procedure. So that's, you can see, an important issue in quality is, are you performing a good quality examination? The same thing for gastroscopy now, is that this is a software which records what percentage of the stomach and the esophagus and the small intestine have you seen so far. So on the right, you can see it's giving you a check mark that you've looked at the vocal cords. It gives you a check mark. Have you examined the entire part of the stomach or not. It's putting check marks for you. So it's almost in a way that there is a second pair of eyes in the room with you when you're doing the procedure, almost guiding you, but also keeping a check on the quality of the examination that you're doing. So we have to move from quantity to quality. And that's again an area where AI can help us in the field of gastroenterology. And it's also automatically recording message or the photographs for you while you are doing the procedure. Natural language processing. We've all heard about that since ChatGPT came about. That's based on a chatbot, which is NLP or natural language processing. And we need that for a clinic encounter. What does that mean? What's a clinic encounter? So when you're sitting, chatting with the patient, somebody, which is the computer, is actually listening to you and is listening to that conversation between the doctor and the patient. Well, anybody can listen to that conversation. But because it's smart and because it's artificial intelligence, it's able to convert that into text, so natural language processing. And so here's an example in which the patient on the left is giving his history, the doctor on the right is listening to the patient, and in the background, the computer is scribing the report that, okay, the patient has symptoms of chest pain, some pain in the stomach, etc., etc. And it's recording and it's scribing all that. It's giving the date when the encounter took place, what time did it happen, what was the examination, and it's also putting in the codes for abdominal pain, for pharyngitis, etc., what those disease codes are. That's also being put at in this situation. And again, ChatGPT is there, and a number of our patients will use it. They can ask ChatGPT about the condition. We have medical students, resident doctors, DNB students who may also participate and ask ChatGPT. And also physicians can ask ChatGPT about these. But remember that ChatGPT wasn't trained specifically on the medical literature, so the responses can be inaccurate. So we still need that human to look at the responses and make sure that those responses are accurate. And so these large language models, and this is a paper we wrote in Nature, talking about can help us for clinical documentation as a summary tool, can help in clinical trials, but you have some concerns which are listed here as well. And what is needed for these for the future is some quality metrics, which also need some regulation as well, because we are not sure how reliable this is, how truthful this is, specifically in the. And finally, AI will also help with drug discovery. This is the traditional, those of you on the call who are into pharmaceutical trials. Traditionally, the way you do it is you identify the targets, you develop these compounds, and this is the traditional way of doing this. If it's AI-based, you can use predictive modeling, high throughput screening, precision medicine, and drug repurposing can happen. And this can just fasten this process of several years to just in months, that all of this can happen with the help of this. It can also help reduce trial costs. This is traditionally how a pharma trial or a study design is done right now. But if you have these decentralized clinical trials, you can lower your overhead costs. There would be no boundaries that you can do it. You could have virtual visits, improved quality with these technology, and you could have real-time data and assessment of these patients rather than waiting for several months for the data to come in. So it can help us a lot with this. So those are the great things, but there are obviously issues, and I'm just listing some of the challenges that we have. Privacy protection of patients, which is a huge thing, right? Data control. The data, is the data good or not? You know, we don't know how these algorithms actually work, and they need to be updated on a very regular basis because medicine progresses pretty fast. So you can't be waiting on the results of data which were done or a model which was done 5 years ago. So we all need to do that. So the way I see this in practice right now is that in endoscopy, it will help us in reducing that miss rate of lesions. And that can be cost saving for us. Photo documentation, that will happen automatically. On the text side, it will help us on the electronic medical records of the patient, and then also help us in doing a much better quality examination for patients that we do. Okay. Now let's move from AI. The next disruption I see is these surgery sparing endoscopic therapies that we do. Okay. So what do I mean by that? Well, that is endoscopic resection of gastrointestinal cancers. Traditionally, this has been done by the surgeons on open laparotomy, things like that, but now we can do this endoscopically. Here's an example of a patient with an early cancer in the lower part of the esophagus, which is an adenocarcinoma. Here we are removing this area of cancer with the help of a snare after creating a pseudopolyp, and then you resect it endoscopically. And so you can prevent surgery in these patients to do that. And we have long-term data which shows that this type of therapy can be extremely helpful to our patients, organ preserving, and can happen on an outpatient basis. So this is for early cancer. That was endoscopic mucosal resection. You can also do endoscopic submucosal dissection. This is an early cancer right at the gastroesophageal junction. Here, what we are doing is we are marking that area. So you mark the area as to what was the abnormal area of the cancer, and then you inject it with fluid, and then you start with the circumferential incision, and you cut around all the margins of the cancer, and then you dissect below the cancer in order to get free margins, and then endoscopically remove that cancer with the help of this. Similarly, you can do this in the stomach as well. So these are all examples of minimally invasive therapies that we can do endoscopically. And this has been a huge disruption in the industry because no longer do these patients need massive surgeries. Here again, that same concept. This is early gastrointestinal or gastric cancer. This is huge. It's almost 8 to 10 centimeters in size. And again, you follow that same concept as I told you. This is looking at it with the help of advanced imaging technique. You've injected with the help of a blue dye, and the reason you inject is because you want to raise the lesion above the muscle layer, because if you go too deep, you can obviously cause a perforation, which you don't want. And then you start your submucosal, as the word stands for, below the mucosa or the top layer, dissection. So what you're doing is marking the lesion, raising the lesion above the muscle layer, and then gradually, just like a surgeon would do, you keep cutting. But you're doing this all with the help of an endoscope. And this is all happening through the channel of the endoscope as to what this is. And this is gastric cancer resection. So similarly, for esophageal cancer, junction cancer, gastric cancer, colon cancer, and you can see that that's the huge defect with all the cancer, and that's the cancer on the right, which has been resected endoscopically that can be done. And these are just some data. This is just a recent study showing that when surgery was compared to endoscopic therapy, surgery was as good. And in fact, ESD, or the endoscopic therapy, had no difference in bleeding, and there was no difference in recurrence of cancer between the two techniques. But you can see the advantage that this is an outpatient technique which can be done. Similarly, minimally invasive technique for this motility disorder called achalasia. In the past, this was treated with surgery. Now you can treat this with what we call POEM, which stands for per oral endoscopic myotomy. So in this, again, what we do is go into the esophagus and you create a submucosal tunnel across the length of the esophagus. And the problem in achalasia patients is a very high pressure zone at the gastroesophageal junction, which means that the muscle the pressure is so high that it prevents the food from going down, and the patients develop dysphagia or difficulty swallowing. So this can be done, as you can see, endoscopically. You've cut through the muscle layer, and then you can clip the incision that you had caused. And then this way, you're creating what's called a POEM. Long-term techniques up to 6 years, and now we have data up to 10 years that it's 90% effective as a technique for treating this motility disorder in the esophagus. And the good news is all these procedures are being done in India, and these patients can be treated with minimally invasive techniques. Finally, GERD, gastroesophageal reflux disease, which is very common in India, and patients can be treated very successful with medical therapy or drugs, but some patients may want it to be treated endoscopically. So here's a technique in which, rather than going to surgery, which can also treat GERD, this is sort of something in between medicine on one side and surgery, which is invasive on the other side, by full thickness plication at the valve. In achalasia, where the valve is too tight, in GERD or reflux disease, the valve is too loose. That's why you have reflux of the stomach contents into the esophagus. So here you can see endoscopically, you can put these stitches or sutures right at the valve, and this will prevent reflux of contents. This is a study actually from India done in Hyderabad, in which patients were randomized, and the two groups between full thickness plication and without full thickness plication were compared. And these are data at 1 year, but also at 3 years. Patients who underwent the full thickness plication had an improvement in their health-related quality of life, which is shown on the left. And PPI, which is a drug therapy, they were able to get off of medical therapy with the help of this therapy. So these are all minimally invasive therapies. So it's a very minimally invasive approach. You preserve the anatomy because you leave the organ behind. You don't cut the organ out. There's a reduced risk of complications. And of course, the vast majority can be done in the OPD or the outpatient setting. And if some patients require hospital stays, it's very short stay as compared to a prolonged stay. So this is the second disruption, which is here. It's already there, and it's here to stay, which is being done on a routine basis in the field of gastroenterology and endoscopy. So this is one disruptive technique. Now, let me focus and shift gears on another disruptive technology in the field of gastroenterology, but perhaps also in other fields. But of course, I'm talking about non-invasive screening of cancers, because as gastroenterologists and endoscopists, we love to do procedures, and procedures are life-saving. And they can also diagnose cancers and is used as a screening tool. But on a population basis, can you have more of a program for the entire country for screening of large populations of patients? And so the reason you need that is because cancer can progress silently. There are good treatments for it. If it's detected late, the healthcare costs go up because the cancer is detected at a late stage. So there are financial implications both to the patient, to the society, to the government, or whoever is paying for it. And of course, there are emotional costs as well, which can't be measured when patients develop late stage cancer, and that's why you need screening tools in there. These are some data which are about 5 years old of looking at cancer trends in India. You can see in 1996, stomach cancer was the number one cause of cancer. Today, it's still the number one cause of cancer. You can see esophageal cancer is at number 9. And you can also see that the other cancers in blue or red are the ones which have actually gone up, such as breast cancer, lung cancer. Colon cancer has gone up. So gastrointestinal cancers are very important because in the top 10, you have stomach, colon, rectum, and esophageal cancer in that. And these are listed here according to the GloboCan numbers for India in 2020. These are important cancers to do. Now let's look at, traditionally, we would diagnose these by endoscopic methods, which still remains the gold standard. Here's one way that scientists have been looking at. This is called a cytosponge, which is a small capsule attached to a thread or a string. The patient swallows it. It goes into the stomach. And then once it's in the stomach, the capsule dissolves and it turns into a sponge. And then what you can do is you can bring the sponge and you can move it back and forth with the help of the string. And the concept is that the sponge will collect cells of the intestine as it is being pulled back. And then you analyze the sponge results, whether there is cancer or not. And these are just some data which were done in the UK in about 13,000 patients. And it showed that the diagnosis of a precancerous condition, which is called Barrett's esophagus, was much higher when the cytosponge was used. And of course, patients had sore throat by doing this procedure. And so it may not be routinely done, but is, again, a non-invasive way of doing it. For the upper GI tract, how about for colon cancer, which I told you is also an important issue and can be a problem in India as well. Again, colonoscopy is the gold standard for doing it. This is a study which showed that when colonoscopy was done, the incidence and mortality, if you look at the study as compared to historical controls, was significantly lower, showing that colonoscopy can reduce both the incidence of colon cancer and mortality from colon cancer, and is one of the techniques which has been shown to do that. So it is still the best test to do, but it has drawbacks. It's an uncomfortable procedure, requires bowel preparation, sedation. If sedation is used, you need time off of work, is relatively expensive, invasive, and complications are uncommon but can happen. So from a population perspective, you may think that you need other markers, such as a stool-based test. This is called FIT, or fecal immunochemical testing, which measures the amount of stool in your blood. So this has been used because it can be a minimally invasive test for colorectal cancer, which can be done. The traditional way of doing it was called FOBT, or fecal occult blood testing, which is no longer used. It's been replaced by this FIT stool blood test. The other is a stool DNA test. So can you just we all shed cells in the stool, so you measure the DNA in there, and can you use the shed DNA and you look for a number of DNA markers in the stool which are being shed, which can be done. So these could be used as minimally invasive testing, and this can be a sort of a disruptive technology, because all of a sudden you can screen the entire country if you wanted to with the help of these testing. That's all good, but you have to show how good is it? How good are these stool tests? So this is a study comparing multi-target DNA test, or the stool DNA test, to the FIT test to the colonoscopy test, and you can see that it's about 90 to 92% sensitive when you compare this to the FIT testing or to the colonoscopy. And these numbers are given here when the study was done a few years ago. In general, when you look at the performance of all of these, I'm giving you these pooled numbers. For colonoscopy, the sensitivity is extremely high. The specificity is close to 90%. For the stool test, which we don't do because it has a very low sensitivity, can be as low as 50%, so it's not done. The FIT test has a higher sensitivity of closer to 80%, 88%. The stool DNA test has a little bit higher, but it can be a little bit lower in some studies. And this is the most recent study done a few months ago, not stool DNA, but stool RNA. And the investigators thought that maybe stool RNA could be better than stool DNA. Unfortunately, the results were very similar to the stool DNA testing when it compared stool DNA to the FIT testing in this study, which was just published in the US of more than 8,000 patients who were testing. So what's the bottom line on non-invasive testing for colon cancer screening? It has lower sensitivity as compared to colonoscopy, but the specificity is comparable. It's less cumbersome, less risky, has the potential for higher uptake. However, on the downside, it needs to be repeated more frequently. It has the potential to meet the unfilled need. What's the unfilled need? If you want to screen a larger population, and maybe many patients don't want to undergo procedures such as colonoscopy. However, we will need more sort of programs in place, education and awareness, so that this can be implemented at the population, state, regional level in these disruptive technology for screening for GI cancers as they are becoming available. So what I think in the future, what will happen to screening is you will have image-based testing, such as, you can swallow a capsule, which will take pictures of the entire GI tract. You will have blood-based testing, which are being tested right now. So you'll have a blood-based test for some of these things. And that will be multi-omics. You've heard of proteomics. You've heard of other omics, genomics, but this will be looking at all omics together. And so simple blood-based test in the future will be able to test you for multiple cancers. These are being tested right now. Some of them are commercially available. You may have heard of this, but I don't think they are there to be applied on the routine setting. I think they're still being tested and need more evidence for that. But this is what will happen as a disruption in the field of screening for gastrointestinal cancers. Lastly, something which is also very relevant is disruption in the field of obesity and weight loss, which we all know is a major issue. It's a pandemic now. So very similar to COVID-19 that we had, right? Obesity, according to the WHO, is now a pandemic. More than 6 of 10 men, this is global, are overweight or obese, and 5 of 10 women are overweight or obese in the entire world. And this shows you the distribution. India and Asia is still in the green, which is good news. The bad news is we are trying to mirror the West and are trying to begin becoming more and more obese. And these are data specifically from India. You can see that the overall obesity rate is 5%, but in certain states, such as the South states as you go, obesity rates appear to be much higher as compared to the Northeast, for example. Even around the Delhi NCR area and in Punjab, the rates seem to be quite high. So again, depending on where you practice, the obesity rates can be extremely high in India as well. And this is the pyramid of how we typically look at it. You start all subjects off, which we all should be doing irrespective of obesity, is lifestyle modification. Then there is drug therapy. We'll talk about that. Surgery, again, which is on the top for the very few patients. But now we have also endoscopic therapy, which we call bariatric endoscopy, which may be the gap measure that we need for patients who are obese, also requiring that. Let's look at different diets. So we did a study in which we looked at the keto diet. Again, it's one of those diets, high fat, moderate protein, low carbohydrate. So you induce ketosis in the patient. Okay, so this is the keto diet. Intermittent fasting. I mean, all of us have heard about this, in which you follow a pattern in which you have about 16 hours of fasting. Some people say it should be 14 hours, 15 hours, 17 hours. No matter what it is, the bottom line is that you have an eating of fasting alternating with eating. So we had about 23 studies with it. And then this was a plant-based diet, which could be for the vegetarians or the vegans, in which they have a dietary emphasis on unprocessed plant food, and you don't have any animal products in there. And then you have these different diets that you can be following. There are other diets too, Mediterranean diet, Atkins diet. Every day there's a new diet which comes out. So it's very hard to keep track of that. But nonetheless, what we found is no matter what any of these three diets, it showed a significant reduction in weight and BMI, or body mass index. Blood pressure changes in your blood sugar were not consistent and cannot be very reasonably ascribed to that. However, after 6 months of these diet, most of the patients started gaining weight. Why? Because when they were on the diet, they were exercising. But as soon as the study stopped, they stopped exercising as well. So they started gaining back weight. So just remember that, is that there can be a lot of benefits of these, but it has to be done in conjunction with other things or lifestyle changes that you do with some of these things, such as which is shown here on this slide to do that. This is change in VO2 max, which is performance measures. And again, there wasn't a significant difference with performance measures as well with these different diets. How about medications? You all keep hearing about this. These are the medications which I would say are the older weight loss medications, which typically are not used right now and had side effects, etc. And so not very popular these days. But these are the new ones. You've all heard about this, the GLP-1 receptor agonist, or the GLP in short, that you heard about this. Semaglutide, which has taken the world by storm. And I like to call it also the Hollywood drugs, unfortunately, because there are a number of people who are taking this just for weight loss, although these are typically for anti-diabetic drugs. That's how they have been used. And this is how they work, is they increase insulin secretion, they decrease insulin resistance, they decrease your appetite, decrease visceral fat, reduce inflammation, and they have a lot of protective effects. So these are sort of the new kids on the block, and all of us know about these, but I just wanted to share some data on how this is used. So semaglutide, as you know, this is how it probably should be used. Start with 0.25 milligrams for 4 weeks, then 0.5, you keep doubling it until you reach the maintenance dose of 2.4 milligrams. That's the maintenance dose, which happens with this, and it comes in different, doses, which are shown here. This is the study which, showed that this was taken. You can see subcutaneous use of this phase 3 randomized trial, and you can see that this dose, and this study went up to 104 weeks, and it showed benefit right up to that time period. So up to 2 years, this weight loss is maintained with this situation. Average weight reduction was 15.2% after 2 years of therapy, which was done. This is another new drug, tirzepatide, and this is also a GIP agonist, which is there. And this is also now taking us by storm. And this is also available. Phase 3 trial of looking at it once weekly, subcutaneous, 5, 10, or 15 milligrams. And you can see that average weight reduction was 20% after 72 weeks of therapy, or a year and a half of therapy, when this was used as 15 milligrams subcutaneously, which was done. Okay, so that's the drug therapy. Now, on the other hand, is surgical therapy. Now, in the middle ground, again, as for everything else, we have endoscopic bariatric therapy. We can place a balloon. We can do an endoscopic sleeve gastroplasty, which was done. There's surgical gastroplasty, which is done, in which you reduce the size of the stomach, and this now can be done endoscopically. This is showing how the balloon works. Is you go through the mouth, esophagus, with the help of the endoscope, and you place a balloon in the stomach. And you can see that it reduces the space in there. It also reduces the appetite of the patient, early satiety. And then when you want to remove it, you can puncture the balloon, it deflates, and then the balloon is removed out. That's how it does. And you can see that the percentage total body weight lost with the different types of balloon, I'd say on average is about 5 to 6 to 7% at max, And these are the different balloons which are there in randomized controlled trials which show it. This is something which is very similar to surgery, and it's called ESG, or endoscopic sleeve gastroplasty. The surgeons also do this reduction procedure through surgery and can be done laparoscopically, which is also minimally invasive, but you still need those ports and incisions on the belly. This is done through the endoscope, and you can see through the endoscope, you start putting anchors in there. You can see those blue strings and tags which are coming along, and you can do this circumferentially, as is shown in the cartoon. And then you pull the sutures together, so you're narrowing the volume of the stomach, and this is called ESG, or endoscopic sleeve gastroplasty, and in which there's about a 70% stomach reduction. How good does this work? This is just one study that I'm showing you, in which it showed that at 6 months, there was about a 16 kilo loss of body weight with this in these patients at 6 months. And this now is shown to be effective for 1 year or longer with the help of ESG in this situation. Why is this important? These are trends in the US about the bariatric surgery, which is shown here, such as the sleeve surgery or Roux-en-Y gastric bypass, or the band surgery, which was done in the US. And you can see that the sleeve is still increasing, the Roux-en-Y and the band, laparoscopic band, are now decreasing. The balloon, which is from 2021, was increasing. And so the endoscopic therapies are starting to increase for bariatric or weight loss procedures in the US. And the traditional sleeve gastroplasty is now decreasing, the Roux-en-Y gastric bypass and the laparoscopic band is now decreasing because of this. So the treatment algorithm used to be this, in which surgery has probably the most effectiveness in the right, but it also has the most risk. Medications used to have the lowest efficacy, but I think they've moved up now with the availability of semaglutide, for example, the GLP-1 agonist and the GIP agonist. And those people who don't want surgery, perhaps don't want medical therapy because you need to take it every day or every week, endoscopic options appear again as, I think, disruptive technology, which is available there. Now, there are a number of these other disruptive technologies, but this is what I have focused on. So, in the field of gastroenterology, which is rapidly evolving, and a lot of cutting edge research is being done, these are the disruptive technologies which are there right now. I've talked about artificial intelligence, which is there, here to stay, will help us in all fields of medicine. A number of surgery sparing therapies, which are currently being done globally, including India, for different diseases of the gastrointestinal symptoms. Non-invasive cancer screening will be a major disruptive technology if it's done on a population level basis, whether it's in the districts or in state level population-based screening, which can be done. And then I think the obesity and weight loss management has also become a very rapidly evolving field with now excellent drugs which are available, but also endoscopic therapies which are disrupting this field. Thank you all very much for Manvi, or we can open this up for discussion now. Thank you. Okay, so I'm trying to look at some of the questions and try to go with this. So retinal scans are said to be precise for diagnostic for disorders, and that too in advance for AI. How could computer vision impact the diagnostic tool? And Mr. Rahul is sending this. Again, I mean, I think this is a great question. As you know, the question from the attendee is related to now there are apps available on the phone in which you can scan the retina. And again, this is a computer vision algorithm which has been trained again in patients from the Indian subpopulation of diabetic retinal scans versus those without diabetes. And so the retinal scan can help make a diagnosis of diabetes. This would be a huge plus for people living in the rural areas, where they don't want to get a finger stick or get a HbA1c level done. And so the earlier studies with this have been shown to have a very high accuracy rate. And I think this really will be disrupting the marketplace, perhaps not as much for the metros, but definitely for people who have smartphones now in the villages, in which we can do a large population-based screening for diabetes, which is also increasing in incidence in the Indian population. The next question is real-time performance a concern with deep learning or CNN models? And yes, it is a concern, but the majority of these real-time models right now have been validated in different populations, and that is before the FDA at least approves it in the US. So what you have to be aware of is what's the population that the specific deep learning or CNN model was trained in. We have a lot of CNN models, at least about 5 for colorectal cancer, which has been approved in the US. Some of them were trained in the Chinese population. And so we tell our patients, perhaps that's not the best one to be using in the US population. The other thing is that these are locked, so they don't get trained real time on the data. So these are real time, they help in real time diagnosis, but they need to be probably updated by the companies and the manufacturers on a regular basis. So I think that will be there. There's another question about ChatGPT by Mr. Senthil Kumar. And ChatGPT helps only to some levels. The data are getting in 2023 is updated only to 2021, which is absolutely correct. Generally, the patients are misguided, and that is also true. In some situations, how do we handle when question us regarding relying on AI? An excellent point by Mr. Senthil, and I think this is one of the downsides of AI that we live in today. AI is great when used in the right setting, but ChatGPT, as I mentioned before, has been trained on millions and trillions on data sets, including some of the medical literature, but on everything on Google as well and on other search engines. So it's not just trained on the medical literature. So a number of the responses of ChatGPT could be inaccurate. I think we will go through a worse time today than we went through 20 years ago when the web came about and internet came. And we all remember those patients who would Google up things and then they would come and say, well, I want this medicine because Google is telling me that this is the best medicine for me. I think it will be worse now with these chat bots or large language models such as ChatGPT, which are there. So I agree with Mr. Senthil, is that this is a problem. What can we do to counter it? Well, we need to be, looking at the patient still holistically and giving the appropriate response. And if the ChatGPT response is inaccurate, we should be telling the patient that that response was inaccurate by ChatGPT and that they can have inaccurate responses as well. So I think it's important to do that. So Mr. Amar has a response on what are the risks you foresee in AI in terms of privacy and security. Again, an extremely, extremely important question. And that is the reason why we need regulation and policy in this field of AI. AI everywhere, but specifically for AI in healthcare. Because, if AI is being trained on patient data, which it is being trained on, if there is a security breach, you can imagine that the hundreds and thousands of patient data which the AI algorithm was trained on can suddenly be breached and can be available to the public on the patient. So there's a huge privacy issue. So there needs to be governance in that. And we need to make sure that before we deploy these algorithms in our regular practice, in the hospital setting, that, do you have appropriate firewalls which have been built? If the data is being stored on the cloud, how secure is the cloud? Is the cloud HIPAA compliant or not, which the majority of them are? But more importantly, are those algorithms running on the cloud or not? And if they are, how secure is the data? So an extremely important point that we need about this. The next is, how beneficial is AI-based lesion detection for an experienced gastroenterologist? And again, a very important question. We don't know that answer. I showed you some data. These are some data which we've just accumulated in the last 6 months, showing that it would help non-experts better than experts. So we definitely know that we need to maybe take the non-experts and make them as experts. Can AI do that? Maybe. So that could be the main benefit of AI today, which is that it is there for the non-experts so that everybody becomes an expert. Why should there be some good doctors and bad doctors? Perhaps we can convert most of them into good doctors. So perhaps that is a promise of AI, and that needs to be shown. But at least in that one study I showed you, that is what's there. Again, Mr. Senthil's question is, what is the role of nutraceuticals in the treatment line? It has become a booming, business, in the area of gastroenterology. And again, I think I agree completely. I mean, part of the challenge is this balance between drugs versus what's available without prescriptions or over-the-counter, sort of whether it's dietary supplements, herbal supplements, etc., which are available. They don't go through the same rigor. They don't go through the same approval process as the pharmaceutical drugs do or the prescription drugs do. And then, of course, they're just marketed to the general population from everything that it can cure your diabetes, to it can cure blood pressure, to it can cure cancer. We've all heard about this. So some of them are beneficial. a good example is probiotics, right? Probiotics, if used in the right setting, is extremely beneficial, and randomized controlled trials have shown that it is beneficial in the right setting. Okay. We know that certain things such as vitamin C, other antioxidants can be helpful as well in the right setting. But on the other hand, we know that just taking herbal supplements or some of these dietary supplements for every disease is not going to be helpful. And so, again, patient education or the population education is key. And yes, it's a challenge for us. We see a patient for 10 minutes. And if they're taking 5 supplements and you don't think they're appropriate, it takes time, takes a lot of convincing. They've seen some advertisements on TV and they become convinced that that is the cure. And so it becomes an extremely important issue, but it's challenge. I wish I had a simple response to it, but I think we just need better education in that aspect and make sure that our patients get the correct and the accurate scientific information. And then there's a question about is there impact of race and population on image detection in AI? And again, very important. And this is the whole area of bias in the field of artificial intelligence. What does that mean? Well, I mean, bias is that, we have bias everywhere in life, right? And one bias is based on race and population. There's a good study from the US in which they had a pulse oximeter, which measures the O2 saturation. And they had a device which used an AI technology and was able to check the O2 saturation very accurately in a study. Then when they went to the real life, they found that in some patients, it was not very accurate. The O2 levels were not correlating with the blood O2 levels. And they found out that it was happening mainly in Black patients or African American patients. They went back into the data set and they found was that the AI algorithm was trained mainly on white patients, in which the color of the skin we know is different, the penetration of light is different, and therefore it's a very good example of how, race and ethnicity can play a major bias in the development of an algorithm. So it's definitely there in image recognition also. So we have to be careful. The example I gave of retinal scan, I mean, it's true. If this was done in, a population in Vietnam, I mean, their retina maybe look differently than the Indian retina. So you have to make sure that it was done. The next question from Dr. Rajender is that EUS can become less useful once advanced AI toolkits are available and screening is available. Thanks. I'm not sure it will become less advanced. I would say to Dr. Rajendra is that it will probably help in the better detection of, staging of cancer. As we know, EUS is used for staging of cancer, but especially let's say in the stomach and the upper GI tract, EUS is not very good in differentiating a mucosal lesion versus a submucosal invasive cancer. Perhaps using AI, it may improve its accuracy for doing that. So it may make it more, objective rather than what subjective it is. So I'm not sure it will be less useful. It probably may make it more useful in some of these situations. Next question from Mr. Amit is, where do you see AI and medicine collaboration in the next, 5 years? And, a great question. In fact, in a couple of days ago in the Times, we had a good sort of an interview and a question about that. And I think this AI and medicine is, here to stay. It will be whether we like it or not. We're already seeing it. It's in our smartphones. You now just, it can hear your voice recognition, which is AI based, is there. You go home and you say, hey, Google, play this, my favorite soundtrack, and it will pull, whether you're an Arijit Singh fan, it will pull all of that for you. So similarly, the collaboration in medicine is going to be multifold. It will help in diagnostics, as I've shown you. It will help in algorithm development for risk prediction. So you'll be able to look at a 54-year-old, whether it's a male or a female patient who's a smoker, what their A1C level is, and you'll be able to predict what their risk of complications from diabetes are, or whether they're going to have a coronary event in the future or not in there. The collaboration will be there with chatbots and chat GPT like chatbots, whether we like it or not. And it will help in drug discovery. So I think in all of those, AI will be there. So I think that collaboration will be there definitely for that. I also have, will generative AI be good or effective only for treating early stage of cancer? And so, again, very good question. And, I don't know the answer, whether it's there for treating only early stage cancer. I mean, generative AI or general AI, as we look at it, there have been some studies in which, based on the endoscopic images and endoscopic videos, AI can help also tell you how deep it is, whether it's going into the muscle layer or not. So endoscopists will appreciate, or gastroenterologists, that if it is too deep, you cannot remove it or resect it endoscopically. So AI can help, tell you also the depth of it. So perhaps, there'll be a day in which AI will tell you all of it. It will tell you whether it's cancer or no. If it's cancer, it will tell you whether it's superficial or deep. And if it is deep, it will tell you whether the patient needs just surgery or chemotherapy or radiation therapy, or a combination of the above. And I think that was your next question as well, is about for advanced stage treatment. And that's where I think it will help us with several of these things as they come along. I think it will not be there only for early stage, but for all different stages of cancer when it comes along. So I think a number of those things will be there for all of AI in the field of gastroenterology, as well as in oncology, as I've told you. So I think I've addressed most of your questions, or all of your questions, which are there. And perhaps I'll turn it over to the ET Health now to sort of wrap it up, or close the session, unless we have more questions, which I don't see coming. So yes, Shagun, please.
So, thank you so much. Thank you to all our esteemed attendees for being part of today's enlightening session on technological disruption in gastroenterology. A special note of gratitude to Dr. Prateek Sharma for his invaluable insights and expertise guiding us through the transformative advancements in this field. Your participation and engagement have made this session truly insightful. We sincerely appreciate your contributions and hope the knowledge shared today will shape the future of gastroenterological care. Thank you once again, and we look forward to seeing you at our future events. Also, the recorded version of this webinar will be available on Health TV, found on ethealthworld.com, and also on our YouTube channel. Thank you so much again to everyone for joining us.